is a cruel and unusual punishment. Yeah. And I think, Steve, you and I have been on the, I think we see each other more on Zoom than we ever did on any conference.
I've given a lot of talks in the last 2 weeks. I know that.
Yeah. And I've had a lot of coffee sitting here. Is that a coffee or Diet Coke?
I know.
Hi, Professor Lin. How are you?
Hi, great to see you.
Thanks for hosting this.
No problem.
I wonder whether we can use the, maybe what I'll do is that I'll share this screen so that we have a sort of a nice, reference point for all of us to look at. Is that okay?
Yep.
Okay.
And then we should be able to start soon. Okay, so I think we are exactly 2:30 p.m. So can everybody hear me?
Yes.
So welcome everyone to the Asian Pacific Society of Cardiology and the Asian Pacific Cardiometabolic Consortium Joint Cardiometabolic Seminar. Today we are having a lovely panel with 4 talks. Now we titled this series of talks Updates in New Frontiers because they are not quite the usual talks, and they engage different aspects of cardiometabolic diseases. And with us today, we have 4 esteemed speakers, Professor Hayato Tada from Kanazawa University in Japan, Professor Stephen Nichols from Monash University, Australia, Dr. Natalie Koh from the National Heart Centre, Singapore, and Professor Alan Fong from Sarawak Heart Centre in Malaysia. So first of all, I'd like to thank all the speakers as well as our host for today, Professor Lin with the Taiwan Heart Association. He has the APSC Cloud Service has kindly hosted us, and you will be able to see us as well live on the APSC Facebook and YouTube channels. This session will be recorded, and the timestamp is 2:30 p.m. Singapore, Kuala Lumpur time on the 8th of August, 3:30 p.m. Tokyo time, Japan, and 4:30 p.m. Melbourne, Australia time. So with that, I'd like to invite our first speaker, Professor Tada from Kanazawa University in Japan, to speak about polygenic scores, LDL, and systolic blood pressure on lifetime risk of cardiovascular disease. Professor Tada, please.
Thank you for your kind introduction, and I will be sharing my slide. Can you see my slide now?
We can.
Yes, thank you.
Okay, so let me start. Good afternoon, everyone, and I'd like to introduce a paper focusing on polygenic risk score for coronary artery disease and its relationship with LDL cholesterol and systolic blood pressure as classical risk factors, published in ACC this year. Okay, let me explain why genetic factors are important. The variance of phenotype. I think any phenotypes can be explained by genetic factors and environmental factors. And heritability for a particular phenotype can be estimated by the equation using variance of twins study. According to such studies, lipid levels as well as coronary artery disease are considered as heritable traits. These important facts have motivated us to investigate the genetic elements driving individuals to higher or lower risk for CAD, and also have led us to assess family history of CAD at our clinic for their risk stratification. Currently, medical doctors in the US who want to assess the risk for CAD typically use this calculator. We can estimate the absolute 10-year risk for ASCVD based on several clinical factors, such as age, gender, cholesterol, and blood pressure. It is important to note that some of those classical risk factors, such as cholesterol and blood pressure, are causal factors and modifiable factors. On the other hand, we are now trying to generate a more sophisticated, personalized risk estimator named polygenic risk score based on human genotypes, because we know CAD is a highly heritable trait. A few years ago, we performed a mediation analysis to assess the proportion of contribution by direct effect of genetic risk score, as well as that by indirect effect by known cardiometabolic classical risk factors. And we found that major part of the genetic effect operates independently from the classical cardiometabolic risk factors. So we know very well that genetic risk score is operating independently from the classical risk factors, including LDL cholesterol and systolic blood pressure, which we are using in our clinics today. However, it is still unclear how genetic risk can be combined with classical risk factors, which are modifiable and the current targets to reduce risk. I think those information would be very useful to provide a potential framework for incorporating genetic risk score into clinical medicine. Human genome is so complicated because it comprises as much as 3.1 billion base pair haploid genome and 6.2 billion per diploid genome. But to make it easy, Seik Kasrisen provided a nice figure illustrating a relationship between human genome and diseases. He divides the situation into two groups based on allele frequency and its effect sizes. In this figure, x-axis represents allele frequency and y-axis represents effect size. Rare genetic variations generally have larger effect sizes, including Mendelian disorders, and common genetic variations generally have smaller effect sizes. And I'd like to share with you the good example of this concept. This study conducted exome-wide analysis on as many as 700,000 individuals to see the genetic factors on body weight. We found a rare, powerful variant in the left upper side, which can drive 7 kilograms per single allele, and many common genetic variations whose effect size is around 10 to 20 grams per allele at the right bottom. So 1 or 2 common SNPs per se typically meaningless in the clinical settings. However, combination of those may lead to exceed or clinical thresholds. So today I focus on common genetic variations. In this slide, I'm showing the power of polygenic risk score comprising 50 SNPs. In both panels, individuals with top 20% of polygenic risk score and family history had higher risk for MACE. And currently, the polygenic risk score comprising 6.6 million SNPs can determine top 8% individuals who have greater than threefold odds for CAD since birth. We can also find other individuals with higher risk for other heritable diseases using the same scheme. So again, it is still unclear how genetic risk can be combined with classical risk factors, which are modifiable and the current targets to reduce risk. So the main objective of this study was to evaluate how much lifetime risk of cardiovascular disease varies at all levels of a polygenic risk score for coronary artery disease, depending on differences in lifetime exposure to LDL cholesterol and systolic blood pressure. Those are both modifiable and causal risk factors. And this study was presented at ACC this year online. They used data from UK Biobank comprising 0.5 million participants. And this slide shows the study population and primary outcome. More than 400,000 individuals enrolled in the UK Biobank were analyzed. Mean age was 57 and followed up for 8 years. Mean LDL cholesterol was 138 and mean systolic blood pressure was 138. Primary outcomes include the first MI or coronary revascularization, and the number of events was 23,000. Time to event analysis were performed and participants censored at age of the first occurrence of a primary outcome event, death due to a cause other than MI or end of follow-up. Genetic risk scores were calculated based on 4 million common SNPs. Those SNPs were essentially divided into 3 categories: 8,000 LDL-associated SNPs, 6,000 systolic blood pressure-associated SNPs, and 4.0 million other SNPs. And polygenic risk score used in this study was the last one, illustrated at the right. And other 2 instruments, LDL and systolic blood pressure, were used to consider their lifetime long exposure to LDL cholesterol and systolic blood pressure. This slide shows the associations between polygenic score and events. Not surprisingly, we can see the robust trends that higher polygenic risk score for coronary artery disease were significantly associated with higher risk for MACE in this slide. And similarly, individuals with the highest polygenic score, colored in green, had the highest number of events compared with the middle risk, colored in red, and the lowest risk, colored in blue. However, when the authors divided the individuals with the middle CAD genetic risk into 2 groups based on genetic risk of LDL and systolic blood pressure, the upper dotted line indicates the individuals of middle PGS for CAD and higher 10 milligram LDL, 2 millimeter mercury systolic blood pressure than average. And the lower dotted line indicates the individuals of middle PGS for CAD and lower 10 milligram LDL and 2 millimeter mercury systolic blood pressure than average. So this slide indicates that genetic risk for CAD is critically affected, attenuated by lifetime exposure to LDL cholesterol and systolic blood pressure. And this figure is indicating essentially the same message. X-axis represents polygenic risk score quintile, and Y-axis represents the cumulative lifetime risk of MACE to age 75 years. So it is easy to understand that the individuals classified in the right side had higher events. However, the authors further divided individuals into 5 groups based on lifetime exposure to LDL and systolic blood pressure. And dark blue indicates the lucky individuals genetically exposed to the lowest LDL and systolic blood pressure, and red indicates the unlucky individuals genetically exposed to the highest LDL and systolic blood pressure. They found that risk for MACE are also substantially different according to the degree of lifetime exposure to LDL cholesterol and systolic blood pressure. Next, they compared the effects on events between lifetime exposure estimated from Mendelian randomization in the left panel and short-time exposure observed in clinical data in the right panel. X-axis and Y-axis represent the same as the previous slide. We can see the great difference between left and right in terms of event rate. However, the trend itself is the same. It is quite reasonable to see the difference because Mendelian randomization in the left panel, which accounts for lifetime exposure to LDL cholesterol, systolic blood pressure, and assessed cumulative lifetime risk, had larger proportions of event rates. And the degree of difference are larger compared with the left panel, which is an observational data of LDL cholesterol, systolic blood pressure, and assessed a short time incident of MACE. And similarly, they compared expected absolute risk reduction from lowering LDL cholesterol by 30% under the assumption of relative risk reduction of 20% per 1 millimole LDL cholesterol reduction. In the left panel, the individuals with the highest polygenic risk score and the higher LDL systolic blood pressure exposure are expected to have great benefit, lifetime risk reduction from LDL cholesterol reduction by 30%. On the other hand, in the right panel, such individuals with the highest polygenic risk score and the higher LDL systolic blood pressure exposure have great benefit from LDL cholesterol reduction by 30%, but the absolute risk reduction of short-term risk is smaller than lifetime risk. So they concluded that lifetime risk of cardiovascular disease varies substantially at all levels of polygenic risk score for CAD, depending on differences in lifetime exposure to LDL cholesterol and systolic blood pressure. Therefore, combining information about lifetime exposure to LDL and systolic blood pressure with the PZS for CAD should more accurately estimate lifetime risk of cardiovascular disease, more accurately identify individuals who may benefit from early interventions to reduce risk, and better estimate the potential benefit from early interventions. When combined with LDL cholesterol and systolic blood pressure, polygenic risk score for CAD has the potential to help personalize the prevention of cardiovascular disease by helping to identify individuals who may benefit the most from early interventions to minimize the cumulative effects of lifetime exposure to LDL cholesterol and systolic blood pressure. Also, it is important to recognize that the trajectories of lifetime risk for cardiovascular disease predicted by polygenic risk score are not fixed. At the same level of polygenic risk score for CAD, individuals with lower lifetime exposure to LDL cholesterol and systolic blood pressure had a lower trajectory of risk for cardiovascular disease, suggesting that the trajectory of cardiovascular disease risk predicted by a polygenic risk score can be reduced by lowering LDL cholesterol and systolic blood pressure. And individuals with low lifetime exposure to LDL cholesterol and systolic blood pressure had a low lifetime risk of cardiovascular disease at all levels of polygenic risk score for CAD, suggesting that LDL cholesterol and systolic blood pressure, which are modifiable, may be more powerful determinants of lifetime risk than polygenic predisposition. Thank you for your attention.
Thanks, Professor Tada. That's a very, very nice talk, illustrating the use of polygenic risk scores, but perhaps more importantly on the modifiable powers of systolic blood pressure and LDL. So I will get the ball rolling with one question for you. How do you see us using polygenic risk scores then? If it is, if LDL and blood pressure alone are such powerful risk factors, why would we want to use polygenic risk scores?
Excuse me. So, could you repeat my comments? And because the internet is very weak now, so
I was saying that since the LDL and the blood pressure are such powerful modifiers, how do we expect to? How should we consider using polygenic risk scores in practice? Will it be a useful tool given that very basic tools like LDL levels and blood pressure are apparently more powerful predictors?
Yeah, it's a very good point. And so I think the authors are very acknowledging that LDL cholesterol and systolic blood pressure are very powerful predictors and modifiable predictors and very important factors because which are modifiable. On the other hand, polygenic risk score is also very useful because it is determined at a very early phase in life and which is also, modifiable by reducing LDL cholesterol and or reducing systolic blood pressure. So I think the assessing both elements, both issues would be very useful. So it is very different and sometimes it is associated with each other, but I think classical risk factors and also polygenic risk score are independently important for us.
KK, maybe I can make a comment. I'm a co-author on this presented paper, and I think there are two parts to this story. And thank you, Dr. Tata, for presenting that so elegantly. First of all, I think it does highlight the importance of lifetime kind of risk and the importance of blood pressure, LDL, and modifiability. But the question you've asked, KK, is really the big question in the room moving forward, is that now we've got a number of reports showing that polygenic risk appears to be important. How do we use it in the clinic? And we don't have the answer to that quite yet. We have really a need to now move observational data into the implementation phase. But one of the things that we really wanted to understand was how important was a polygenic risk score going to be if you varied the LDL and the blood pressure the way that we did. And as you saw in the presentation, the relative importance of a polygenic risk score can be altered quite markedly if you have people who simply have a lower LDL or lower blood pressure. And so I think that's going to really play into the question of what it looks like in the clinic, which is why I think the next series of studies are really important.
Thanks, Steve. Any questions from Alan?
Not yet at the moment. Thank you.
We might have some questions as these series of talks are presented. But in the meantime, perhaps we can go to our next speaker. And it gives me a great pleasure to present, to ask Professor Steve Nichols from Monash University in Australia to give a talk on the eicosapentaenoic pentanoic acid levels in REDUCE-IT and CV outcomes. Steve, please.
Thanks, KK. And for the ease of pronunciation, I'm going to just refer to it as EPA throughout the next 15 minutes. There's been a lot of activity in the omega-3 fatty acid fish oil space in the last few years, and there's been a lot of exciting data in particular to emerge from the REDUCE-IT study. So it's a great pleasure to be able to kind of review what we know about really EPA levels and cardiovascular risk to date. This slide summarizes my disclosures. So the story of fish oils goes back for many decades. We have cohort studies showing that greater dietary consumption of fish oils and omega-3 fatty acids associates with less cardiovascular events. We know that from those studies, is an inverse association between the concentration of omega-3 fatty acids within red blood cells and cardiovascular risk, suggesting that tissue levels are important. Now, we saw from the GISI studies prior to the generation of statins that there were early reports of cardiovascular benefit for fish oils. However, a large number of studies that were subsequently performed over the course of the next 2 decades really were disappointing, and that was kind of confirmed by meta-analyses that really questioned whether omega-3 fatty acids or fish oil were preventive at all. We've had 2 really important outcome trials presented in the last 10 to 15 years. The first was JELIS from Japan, more than 19,000 patients. And you saw in that study that administration of 1,800 milligrams of EPA on top of a statin produced a 19% reduction in cardiovascular events compared to statin monotherapy. That was an open label study. It was a large study, but it was favourable. In fact, not only was it favourable, but there were particular subgroups who really derived greater benefit, and those were patients who had a prior MI or patients who had a higher baseline triglyceride level at the entry to the study. But what we subsequently saw was a report suggesting that there was even a greater benefit in those achieving higher plasma levels of EPA. And what we've subsequently seen is that, particularly in Japan, EPA has been very widely used for cardiovascular prevention in many patients. Now, in more recent years, we've seen the results of the REDUCE-IT study. REDUCE-IT is a large outcome study, more than 8,000 individuals. These were all statin-treated patients of at least 45 years of age. They either had to have established CVD or diabetes with at least one additional risk factor. They had to have a triglyceride level between 150 and 500 mg per deciliter, and they had to have an LDL cholesterol that was pretty well treated. And patients were treated with 4 grams per day of pure EPA in the form of icosapent ethyl or placebo. And they were followed for an average of about 4.8 years, with a primary endpoint being a fairly standard CV endpoint for large CV outcome trials, composite of CV death, non-fatal MI, stroke, coronary vascularization, or unstable angina requiring hospitalization. Here you see both the primary and key secondary composite endpoints, and really it was a blockbuster result. Compared with a mineral oil placebo, administration of icosapent was associated with a 25% reduction in the primary composite endpoint, and importantly, a 26% reduction in the key secondary composite endpoint of CV death, MI, or stroke. You see that those curves take a little while to separate, and that is very consistent with a lot of anti-atherosclerotic and lipid-lowering cardiovascular outcome trials. What we subsequently saw was not only was there a reduction in the first cardiovascular event, but in fact there was a reduction in total cardiovascular events. And that is an important finding because we know that there are patients who are particularly high risk who will not only have one event over their time, but they may have multiple events. And that has important cost effectiveness implications for healthcare systems. It has important implications for the patient and the patient's family. So I think, again, the fact that that was kind of extended to show that there was, in fact, a 31% reduction in total events is a really important observation. So what they've reported at the ACC this year was an interesting analysis that looked at EPA levels. First of all, if you looked at patients stratified according to baseline tertiles of EPA, whether you look at the primary or the secondary endpoint, secondary composite endpoints, you see that there is a benefit in favor of icosapent compared to placebo that is observed at all levels of EPA at baseline. So it didn't matter how high your EPA was coming in, you benefited from being given 4 grams of icosapent daily. Here you see the changes in icosapent and EPA levels within the serum in the icosapent and placebo groups over time. Not surprisingly, in the placebo group, EPA levels did not change over time, but in the icosapent group, you saw a median percent change of EPA in the order of 363%. So these are highly robust increases in EPA levels. And for many of us who have been arguing that cardiovascular outcome trials of omega-3 fatty acids had to involve higher dose administration, it really was all about achieving much more substantial increases in plasma, serum, and ultimately red blood cell kind of levels of EPA with or without DHA. And so you see that the study really achieved that. Now, what the authors were able to present at the ACC was in fact looking at the relationship between the hazard ratio for benefit of EPA versus placebo, so these are not crude event rates, these are the hazard ratios, versus an area under the curve for the daily average EPA levels. And acknowledging that in everything that I'm about to show you, the confidence intervals become very wide at the highest levels. And so I would kind of, caution any interpretation of any change in the slope of the curve that one wants to kind of think they observe with all of this. But it's important to observe whether you look at the key endpoints, the primary endpoint, that key secondary endpoint of CV death, MI and stroke, cardiovascular total mortality, the higher the achieved level of serum EPA, you see that hazard ratio appears to be more favorable in benefit in terms of icosapent versus the mineral oil placebo. What if we look at a number of other endpoints, any myocardial infarction, any stroke, any coronary vascularization or unstable angina, i.e. we look at each of the individual components of the primary endpoint, you see again, the higher the daily average level of EPA, the greater the hazard ratio appears to be in terms of suggesting benefit for icosapent versus the mineral oil placebo. Now, what if we look at the patients who had either established cardiovascular disease coming in the secondary prevention cohort, or whether we look at the patients with diabetes with at least one additional risk factor, i.e. the primary prevention patients? Again, we see the same thing. The higher daily average EPA level, apparently a more impressive hazard ratio in favor of icosapent compared to mineral oil placebo. And then finally, a number of additional endpoints that are worth noteworthy. Sudden cardiac death, cardiac arrest, new heart failure requiring hospitalization, or new heart failure in general. Again, it doesn't matter what endpoint you look at, the greater the area under the curve daily average EPA level, you appear to be more favorably treated with icosapent compared to placebo. There are a number of limitations to this analysis that were acknowledged by the authors. 14% of the patients did not have baseline EPA levels, though the baseline characteristics and outcomes between those with and without missing data were similar. The on-treatment dose response analyses for the hazard ratio, looking at some of the safety factors that have been looked at in the study, in particular bleeding, serious bleeding, and atrial arrhythmia, are not yet available. The results they appreciate are only applied to the specific icosapent ethyl formulation of EPA, although, as I've shown you, there is data from GELIS suggesting a similar type observation from that study. And then finally, it's important to acknowledge that there are omega-3 fatty acid mixtures that do not contain just EPA. And it may, that is an important point to kind of consider moving forward. I make that last point acknowledging that there is another cardiovascular outcome trial, one that I am part of the leadership, called STRENGTH. STRENGTH is a slightly different study. The study cohorts are similar, 13,000 patients, high vascular risk with both modest hypertriglyceridemia, but importantly with a low HDL cholesterol level. They are randomized to treatment with EPA and DHA, so it's a combination of omega-3 fatty acid kind of formulation, again 4 grams, versus a corn oil placebo. Again, the placebo is quite different than the placebo that was used in REDUCE IT. And that study, which is a standard cardiovascular outcome trial, was terminated prematurely in January. We made a public announcement about that due to the low probability that the study would show benefit. We are putting the data together at this point in time. So we look forward to kind of sharing the results of that study soon. It will be important to know if a similar relationship is observed between EPA levels and cardiovascular benefit in that study. We will only be able to know that when we have all of the data to be able to present. Similarly, STRENGTH will permit the evaluation also of the association between DHA levels and cardiovascular risk, given that we would expect to see an increase in DHA levels with the administration of the fish oil in that study. So finally, in conclusion, there are cohort and clinical trial data that suggests an inverse association between EPA levels and cardiovascular risk. the true mechanism that links EPA and cardiovascular protection remains to be elucidated. The impact of other omega-3 fatty acid species on CV risk remains to be determined, and maybe strength may give us some insights with regards to that. Finally, these findings are important because they have critically important implications for both the public health and pharmacological use of fish oils. And I think that they will warrant further kind of investigation and discussion, because it will be critical for the way that we use these agents for the prevention of cardiovascular disease. On that note, I'll thank you for your attention.
Thanks, Steve, for that very nice summary of the REDUCE-IT trial. Again, I'll start off with a question. So can you share maybe quickly what is the mechanism of action for EPA and the fish oil? How is it generally thought to be related to?
Well, I think it's probably going to be a combination of things. I think what we've learned is that EPA not only has a favourable effect on atherogenic lipoproteins, we know that they reduce levels of APSC-3, they reduce triglyceride levels, they probably do have a favourable effect on HDL. But we also know that, at least in the lab, that EPA and DHA to some degree are anti-inflammatory, antioxidant, antithrombotic. They do act as a membrane stabilizer, so there is a view that they may be anti-arrhythmic. It is interesting when you look at the event curves from REDUCE-IT and GELIS, however, it does take a while before they separate, and that would suggest more an anti-atherosclerotic effect rather than an antithrombotic or a anti-arrhythmic kind of effect in those studies. But again, clinical trials don't tell us about mechanism. They can give insights, but I would suggest it was a combination of the lipid and the inflammation differences between icosapent and the mineral oil placebo that translated to the results that we saw in the study.
Thank you. Our other speakers and panelists, any questions for Steve? Oh, yeah, hi. Yes, Alan.
Yeah. Hi, Steve. Can I just ask? I mean, for the EPA use in the trial, was it one that was synthesized, or was it one that was naturally extracted?
It was a synthesized, and that's a really important question, Alan. You'll notice that I finished my discussion talking about the public health and the pharmacological implications. And the reality is that many of our patients take fish oil. In fact, many of them take them and we don't even know about it. Fish oil is easily available over the counter, but not all fish oils are the same. And I always get my patients to bring in their fish oil, and I actually read to them how much EPA and DHA they're getting. A lot of those fish oil preparations contain about 250 milligrams of EPA or DHA, which simply isn't going to be enough. Now, if they're taking the fish oil for another reason, that's fine. But if they're taking the fish oil because they think that's going to prevent a heart attack, I very quickly tell them that it's not. So, you know, I think it's going to have to be giving substantial amounts of it to get into the plasma, to then get into the red cell, which really reflects the tissue kind of penetration that's going to be important.
Right, and that's very important. I think there's a lot of public health messaging here, including new industries. And one of the new industries they are looking forward to push post-COVID is aquaculture. And, you know, they're looking for added value in the kind of fish that they are going to farm. And I think and this kind of trials and information could actually help in the selecting of the kind of fish that perhaps could provide naturally occurring EPA.
Oh, absolutely. And you know, there are implications for, you know, it's exactly the same conversation we just had, with Dr. Tata. It's about the lifelong exposure as opposed to the short duration of these kind of clinical trials that we perform. So, you know, I think it is important. We've seen contemporary large clinical trials of much lower doses of EPA, 840 milligrams, not work. So, again, short studies, and maybe asking, in one way, asking the right question in the wrong group of individuals, certainly answering that question for those individuals. And so I think what we're going to learn from these studies is these are not agents for everybody. They're going to be agents that we have to find the right patients for. And I think that's why those subsequent analyses are so important, to try and define where's the sweet spot for where we should use these agents and where we shouldn't. 4 grams of fish oil is no mean feat to ask for a patient. These are big capsules. There is a lot of GI intolerance that comes along with all of this. And so patients typically don't like to take them. They're a lot better than they used to be. The earlier formulations really did give a very bad fishy aftertaste. I think it's really important that we really find the right patient for these interventions.
Right, thank you.
Any other questions for Steve? Okay. If not, let me proceed to our next speaker. Dr. Natalie Koh is from the National Heart Centre Singapore, a good friend, and she's going to be talking to us about DAPA-HF and the benefit of dapagliflozin on first and repeat events in patients with HFrEF in the DAPA-HF trial. Natalie, please.
Thank you, Professor Yeo, for the kind introduction. Hi, I'm Natalie, and I work closely with Dr. Yeo at the National Heart Centre in Singapore. Today, I will be talking about DAPA-HF, a quick summary, and a focus on the analysis of benefit of dapagliflozin on first and repeat events in patients with heart failure with reduced ejection fraction in the DAPA-HF trial. I have no disclosures. Today, I will be presenting the DAPA-HF study, which was first presented in November 2019 and received a standing ovation at the ESC. A little bit of the background. Sodium glucose cotransporter 2, SGLT2 inhibitors, prevent the development of heart failure in patients with type 2 diabetes. The question has always been, can they be used to treat patients with established heart failure, even in those without type 2 diabetes? The group tested the SGLT2 inhibitor, dapagliflozin 10 milligrams once daily, added to standard therapy in patients with heart failure and reduced ejection fractions, both with and without type 2 diabetes. The key inclusion criteria were patients with symptomatic heart failure and an ejection fraction of less than 40%. They had to have an NT-proBNP of greater than 600 picograms per ml. If they had been hospitalized in the last 12 months, the requirement was reduced to 400 picograms per ml. If they had AF, it would be more than 900 picograms per ml. The trial excluded patients with an eGFR of less than 30 mils per minute and with symptomatic hypotension of systolic blood pressure less than 95 milligrams of mercury, and also excluded patients with type 1 diabetes. The primary endpoint was a composite of worsening heart failure event or cardiovascular death. The worsening heart failure event was defined as an unplanned HF hospitalization or an urgent heart failure visit requiring intravenous therapy. The DAPA-HF design was a phase 3 placebo-controlled trial. 4,744 patients with symptomatic HFrEF were randomized to receive either dapagliflozin 10 milligrams once daily or a placebo on top of recommended pharmacological therapy and were followed for a median of 18.2 months. The trial enrolled only patients with HFrEF with a median LVEF of 31%. Approximately half of the patients had diabetes at baseline, and more than 40% did not have underlying IHD. The trial also ensured that all patients were receiving appropriate background treatments and neurohormonal antagonists. Specifically, more than 90% were receiving inhibitors of the renin-angiotensin-aldosterone system and beta blockers, and more than 70% were receiving mineralocorticoid receptor antagonists. The primary outcome of the composite of CV death, heart failure for hospitalization, and urgent heart failure visits there was a 26% relative risk reduction with a number needed to treat of 21 in the dapagliflozin arm. And the components of the primary outcome, in addition, it showed that dapagliflozin reduced cardiovascular death by 18% with a p-value of 0.029, over and above reducing worsening heart failure events. We see that the effect of dapagliflozin on the primary outcome was generally consistent across pre-specified subgroups, including in patients without diabetes at baseline, as can be seen in the red box. Patients in NYHA functional class 3 or 4 appeared to have less benefit than those who had NYHA class 2 heart failure. Of great importance, the magnitude of benefit on the primary composite endpoint was similar in patients with and without diabetes and in patients with or without ischemic heart disease. And I draw your attention to the numbers you can see on screen. In patients with or without diabetes, the relative risk reduction was 0.75 and 0.73 respectively. Some secondary endpoints of note in order of hierarchical testing. The incidence of the secondary composite outcome of cardiovascular death or hospitalization for heart failure was lower in the dapagliflozin group than in the placebo group. Likewise, for total heart failure hospitalizations and cardiovascular death. In terms of symptoms, the increase in the total symptom score on the Kansas City Cardiomyopathy Questionnaire, KCCQ, which indicated fewer symptoms, was greater in the dapagliflozin group between baseline and at 8 months. More patients in the dapagliflozin group had an increase of at least 5 points, which is the minimally important difference in the total score, and fewer had significant deterioration. There was no difference in the worsening of renal function endpoint between the two arms, which was defined as a composite of a sustained greater or equal to 50% reduction in eGFR, development of end-stage renal disease, or death from renal causes. And dapagliflozin was shown in the secondary analysis to reduce all-cause mortality by 17% with a p-value of 0.022. There was no notable excess of any event in the dapagliflozin group. Specifically, adverse events of interest that were looked at were volume depletion, renal adverse events, fractures, amputations, and there was no evidence of major hypoglycemia or diabetic ketoacidosis. There were no serious events leading to treatment discontinuation, no signal for that. And specific to DAPA-HF summary and conclusions, dapagliflozin was found to have reduced the risk of worsening heart failure events and cardiovascular death and improved symptoms in patients with heart failure with reduced ejection fraction when added to standard therapy. The relative and absolute risk reductions in death and hospitalization were substantial, clinically important, and consistent across important subgroups, including patients without type 2 diabetes. Dapagliflozin was well tolerated, the rate of treatment discontinuation was low, and excitingly, dapagliflozin offers a new approach to the treatment of heart failure with reduced ejection fraction. The ESC paper, recently published just in 2020, highlights in their conclusions, currently available data suggests that dapagliflozin could be considered in the treatment of HFrEF even without type 2 diabetes. Likewise, in the just recently published Heart Failure Singapore Society Guidelines, the C Clinical Practice Guidelines 2020, also in the recommendations for SGLT2 inhibitors, in patients with heart failure without diabetes mellitus, dapagliflozin has been noted to reduce the risk of heart failure hospitalization and death, and in patients with HFrEF EF less than 40% who remain symptomatic despite optimal medical treatment can be recommended in the absence of severe renal impairment, defined as eGFR of less than 30. We move on to the exciting part of the talk, which is the benefit of dapagliflozin on first and repeat events in patients with heart failure with reduced ejection fraction in the DAPA-HF study. This was presented in March 2020 ACC by Professor Piotr Ponikowski. I give him thanks for the following data. A bit of background. Among patients with, Among patients with heart failure and reduced ejection fraction, the sodium glucose cotransporter SGLT2 inhibitor reduced the risk of CV death, as I've shown you in the previous half of the presentation. However, it is well known that this trial applied to a time to first analysis. And it's difficult because patients with heart failure will experience more than one hospitalization during the natural course of their disease. And patients at high risk are more likely to suffer recurrent hospitalizations. Conventional time to first event analysis, as presented earlier, ignores all these repeated hospitalizations. Also, time to first event analysis of a composite outcome, like in the DAPA-HF study, ignores death occurring after the first hospitalization for heart failure, and consequently, even the use of a composite outcome does not reflect the full burden of heart failure if analyzed simply by a time to first event. Moreover, time to first event analyses may overestimate the treatment benefit if the treatment effect wanes over time, or if a subgroup of patients does not respond and has multiple recurrent events. So in this study, this pre-specified secondary analysis, the group analyzed all heart failure hospitalizations, both first and repeat, experienced by patients in the DAPA-HF. So this slide is from Professor Tan Yu-san's previous presentation. I referred to it because the statistical analysis was complex and required some understanding, and I've tried to simplify it as much as possible. Let's take a step back to consider the important requirements for recurrent events analysis in the DAPA-HF trial. First, a survival-based methodology of time to every recurrent event is necessary. Simple counting of events is inadequate. At the very least, the event should be correlated to chronic dapagliflozin therapy and its possible discontinuation during the conduct of the trial. It has been reported in a simulation of heart failure RCTs that a discontinuation rate of less than 30% is optimal, and this was achieved in the DAPA-HF study. Second, there must be allowance made for advanced statistical modeling. Standard Cox proportional hazard regression can only handle time to first event. Extensions of the Cox's proportional hazard regression that allow for covariate adjustments and downstream meaningful statistical analyses are necessary. So is the need for competing risk analysis for individual components of the composite endpoints. Thirdly, the default assumption should be a non-uniform subject risk basis, which can be categorized as inter or intra-subject heterogeneity. Inter-subject heterogeneity in risk propensity itself is a violation of Cox proportional assumption, decreases statistical power both in standard time to first Cox proportional analyses, as well as in modified approaches for recurrent events analyses, and increases the divergence between the two. Within subject correlation or event dependency is where the event itself accelerates or decelerates the rate of subsequent events. So in summary, to account for these heterogeneities, newer survival methods have extended the Cox proportional hazard regression using variance-corrected models like the Yingwei-Yang-Ying method and the frailty models, which this study employed. In this study, the composite outcome of recurrent HF hospitalizations or CV death was analyzed by the aforementioned semi-parametric proportional rates model known as the LWYY Yingwei-Yang-Ying method. A second pre-specified method, a joint frailty model, was used to deal with the semi-competing risk of cardiovascular death when estimating the treatment effect on HF hospitalizations. A non-parametric estimates of the marginal mean of the cumulative number of recurrent HF hospitalization rates over time were also calculated, allowing for death as a terminal event and plotted, and this used the method of Kosh and Lin. These are pretty advanced statistical approaches. And I bring us back to the primary composite outcome. Just to refresh our memory, this was what DAPA-HF found. A primary composite outcome, risk reduction of 26% in the dapagliflozin arm and a number needed to treat of 21. And then these are a time to first event analyses for both first heart failure hospitalization and cardiovascular death. This slide shows the recurrent hospitalizations in DAPA-HF. I would like to draw your attention to the fact that among 548 with at least one HF hospitalization, there was 168, nearly 30%, who experienced 2 or more heart failure hospitalizations. This shows us the relative importance of recurrent events. And numerically, among these 548 patients in total, they experienced 809 hospital admissions, again highlighting the relevance of recurrent events. Without the subsequent analyses I will show you, we would miss out on the heart failure burden-related information, a very rich data set. So what were the key baseline characteristics according to heart failure hospitalization during follow-up? This table summarizes all these characteristics, and of note, those with repeated heart failure hospitalizations tended to be older, have more comorbidities, and have more advanced disease, as evidenced by their lower baseline systolic blood pressures. And more often, they tended to have NYHA class 3 heart failure with poorer quality of life, and were more likely to have had prior hospitalization, lower EF, and higher NT-proBNP, basically a sicker cohort. Regarding therapy, patients in DAPA-HF were in general very well treated and received optimal pharmacological therapy and device therapy. But patients with recurrent HF hospitalization were more likely to have ARNI, and this was attributed to the effect of recent adjustment of their therapy during heart failure hospitalizations. And those with recurrent HF tended to receive more often device-based therapy. These are the important results showing the effect of dapagliflozin on the number of patients with 1 or more admissions, and also the total number of hospitalizations between the placebo and the dapagliflozin groups. There was a significant reduction both in the number of patients who experienced 1 and recurrent events, and a reduction in the total number of hospitalization admissions in patients treated with dapagliflozin. This slide shows a comparison between the standard approach using time to first event and also the recurrent event analysis on cardiovascular death or heart failure and heart failure hospitalization. The magnitude of the beneficial effect of dapagliflozin on cardiovascular death and recurrent heart failure hospitalization is 0.75 using the Lin-Wei-Yang method, and the p-value was calculated to be 0.0001. Of heart failure hospitalization relative risk reduction, it is 29%, and a CV death relative risk reduction of 19% when the joint frailty method was applied. Ultimately, this statistical analysis and those numbers translated to a time to first event analysis, CV death or hospitalization for heart failure number needed to treat of 26, and a heart failure hospitalization number needed to treat of 35. And for recurrence events analysis, CV death or HF hospitalization absolute risk reduction had an even lower number of 5.3, translating to a number needed to treat of 19, and an HF hospitalization number needed to treat of 27. So we see dapagliflozin's effect over and above time to first event. It also reduced recurrent events. And in that cohort, heart failure for CV death. To summarize the secondary analysis that mined this rich body of data, Even over a relatively short period of follow-up of a median of 18.2 months, a large number of patients experienced recurrent heart failure hospitalizations. 32% of all hospitalization for heart failure was a second or recurrent event. Patients with heart failure who had recurrent hospitalization had more advanced disease and more comorbidities. Dapagliflozin reduced the risk of both first and recurrent hospitalizations for heart failure. The reduction in risk of recurrent hospitalization for heart failure was more pronounced after accounting for the semi-competing risk of CV death. I thank you for your time.
Thanks very much, Natalie. Steve, maybe I'll let you lead with the questions. You're muted, Steve.
Apologies. Natalie, are we seeing the transition of SGLT2 inhibitors from being a kind of a diabetologist drug to a cardiology kind of drug
Yes.
with these findings?
A heart, yes.
Right. So will that have a flow-on effect to our use of these agents in the patients who the diabetic patient who is in the CCU, where we're not thinking per se about a heart failure outcome, where it would be fair to say that, you know, our use of these agents is still probably less than ideal?
I think when we look at a patient, for me, the most exciting thing about SGLT2 inhibitors would be in the for now with this data, would be in the cohort without diabetes. For them, to me, not being punny, but this is a paradigm shift. I am so excited to have more medication to give with hazard ratios that are comparable to the best in class across all HFrEF therapy.
So yeah.
But when we look at the cohort with diabetes, I am always reluctant to start SGLT2 inhibitors when they come in, if they are not on SGLT2 inhibitors, in a decompensated state. Because we would be dehydrating them, in a sense, we would be giving them IV Lasix, there would be fluid shifts. This is not the best time to initiate SGLT2 inhibitors. And if they were actually on SGLT2 inhibitors, I tend towards discontinuing them and observing their sugars closely because I fear euglycemic diabetic ketoacidosis. The process of diuresis drives the ketosis sometimes. I am very cautious in patients with diabetes who come in with acute decompensated heart failure. So this is a different population. In both cohorts with and without diabetes and with HFrEF, for me, this class of drugs is very exciting. And specific to the cohort without diabetes, armed with DAPA-HF, I feel empowered now to give dapagliflozin upfront if the eGFR is greater than 30. I think we need to make people comfortable with the idea. This is both a diabetes drug, and now I think many bodies have come behind to say, yes, we would like to claim this as a heart failure, reduced ejection fraction drug as well. Let's add to our armamentarium in an affordable manner.
So you mentioned the word paradigm. So which is a nice segue to my next question. So where does this leave us in terms of, you know, Entresto? I mean, if we've got patients with heart failure where they're already on good beta blocker, RAS inhibitor kind of therapy, what's the next agent? Is it changing them over to Entresto, or is it adding an SGLT2 inhibitor?
Very difficult question, Prof. Nichols. Maybe I would open the question to the floor as well. For me, I think I would also like to see the patient. Price, pill burden, polypharmacy, these are manifold issues in a complex patient. So I think there's always room to optimize, but bearing in mind cost and pill burden. Every patient is different. Every scenario is different. Sacubitril, neprilysin is a fantastic drug. Entresto is a fantastic drug. Expensive, but fantastic. I think, I feel put in a spot and I don't really, yeah.
Let me save you from that, and maybe we'll go to the rest of our panel and KK, Alan, Dr. Tada. I mean, so now we're sport for choice. How do we try and work out how we're going to integrate these agents into our practice, KK?
Well, I've been asking that question for a long time, because what metrics do we use in deciding which drug should go first? Is it number needed to treat? Is it time to first event? I think that's a question that nobody really has answered. To be very provocative, I would say, the number needed to treat for the COAP study for mortality, not just heart failure hospitalization, was 5.9. So it beats any of these drugs hands down. So do we offer those therapies first? So Natalie is laughing because she knows what kind of controversy I'll stir with that. But I say I don't have the answer. And I think for now, we have to go by trial design. And trial design means that we put the patients on accepted guideline-directed medical therapy first, for a variety of reasons, cost being one of them, but also established practice and experience with those drugs and their associated complications as another important reason. And then the rest of it can only be formed with greater experience and more studies. So in short, I would say that for now, I will go with whatever has the most data. And if you ask me between Entresto and DAPA, I would say that it's a close fight. I personally would prefer DAPA, if only because of the fact that it's just simply cheaper, and the benefits appear to be beyond just heart failure. Yeah. Maybe Dr. Tada?
Thank you for your comment. And I would choose to use SGLT2 inhibitor for the patients with obesity, because reducing weight is actually good for any situation, right? So in other cases, such as the patients with ring, not obesity, I would rather choose to consider other agents. Thank you.
Okay. I think we might, this has been a really lively discussion, but I'm mindful that we're kind of getting on. So we might thank you, Natalie, for, we could have spent an hour and a half talking about this, I suspect. And I see Alan Fong there smiling, wanting to weigh in, but I'm going to reprieve him from that, because we are keen to go on to his talk to kind of finish the session. And we're delighted that Alan from Malaysia is going to talk about a study that is very important in terms of how we try and put everything together, the ischemia trial, and which continues to be discussed in all of our journal clubs, both virtually and within our own departments, about optimal management of the patient from a revascularization perspective. So Alan, I'm really looking forward to your insights with regards to ischemia.
Thank you very much, Steve. Actually, my lecture is not as exciting as the preceding ones. I think the era of sport for choice in terms of heart failure therapy reminds me of the time when we were just getting drug-eluting stents into the market. When you initially had the Cypher, and then now we have over 50 different manufacturers and brands to come to treat occlusive coronary artery disease. So I think with that and empowerment you were talking about, Natalie, I think we like to go beyond that, and eventually we'll see what Emperor brings us with the SGLT2. So moving on to ischemia, I think I have no real, how do I get this going? Conflict of interest, but I'd like to start with the AHA, which was the last really big meeting in North America, globally, before the COVID pandemic. And this was a very important presentation by, I think, one of my heroes, Judith Hoffman from the NYU, and she presented the international study of comparative health effectiveness with medical and invasive approaches. So the general concept is that the paradigm that suggests why randomized trials have not demonstrated a survival benefit for revascularization in stable ischemic heart disease. And as you know, a severe obstruction presents more with angina compared to a mild obstruction, which may have a vulnerable plaque and which then subsequently ruptures, and then you have your acute MI, unstable angina, and sudden death. So in this kind of situation, this was an issue whether pharmacologic stabilization and early identification of these high-risk patients would actually improve outcomes. So the top line slide and research question is that in stable patients with at least moderate ischemia on stress tests, is there benefit of adding cardiac catheterization and if feasible, revascularization to optimal medical therapy? So the study design was that you had to have moderate or severe ischemia determined by the site, but read by the core lab, and then subsequently undergoing a blinded CCTA, which again, the core lab decides whether the anatomy was eligible. And if that was the case, randomized to either an invasive strategy, which was OMT, optimal medical therapy, with cardiac catheterization and optimal revascularization. The other arm was a conservative strategy, which was not actually conservative, but quite aggressive optimal medical therapy, and cath only reserved for OMT failure. Of course, there are elements of patients where the CCTA was not required, and you look at the left of the screen, and then in these kind of cases, where if the GFR was low, or if the coronary anatomy was previously defined, they would then go on and be randomized. So in terms of the design overview, again, we started with moderate or severe ischemia, definition here by which from echo, nuclear, MR, or actually the standard stress test, and then determined by the core lab, and subsequently undergoing coronary CT angiogram. In this case, you can see the top arm being the conservative arm, and hopefully that patient will remains well. And the other arm was an invasive strategy that would mean undergoing conventional coronary angiography with or without revascularization. So in the study flow, over 8,000 patients were enrolled into the study, but about 5,000 patients are randomized, having had a CCTA done in 73% of these patients, and 2,500 patients, 2,588 patients randomized to an invasive strategy, and 2,591 patients randomized to conservative arm. And in both these arms, the median follow-up was 3 to 3.3 years, and most of the patients completed follow-up. So a very robust trial study design. In terms of baseline characteristics, median age was 64, and predominantly male, 42% of them diabetic. And most of these patients have been pretty well, with 90% of them having stable angina and 75% having positive stress imaging, 25% with exercise tolerance test. As far as the APSC is concerned, and I know this is an APSC-APCMC meeting, 7 of our members of the APSC actually participated. Australia, Taiwan, Malaysia, New Zealand, Singapore, Thailand, and Japan all participated in the ischemia study. But the bulk of the randomizations and enrollments in the United States, United Kingdom, Canada, Brazil, and of course India, which formed 18% of the patient cohort. So this ischemia study also involved pretty much most of the world. The primary outcome of this study was as such, with the red line in the invasive arm and the blue line on the conservative arm. And after 4 years, the event rate for the cumulative incidence of the primary outcome was 15.5% in the conservative arm and 13.3% in the invasive arm, which was not statistically significant, a p-value of 0.34. I draw your attention to the all-cause death, and after 4 years, it was 6.5% in an invasive arm and 6.4% in the conservative arm. And the reason I put this slide up, I'll come back to it later. The most important thing I find in this study, in terms of ischemia with moderate severe ischemia determined by core lab, was that this graph, and this set of curves, looking at the angina frequency score. And there are 3 graphs. Well, the first at 3 months, the second at 12 months, and the one on the right at 36 months. The x-axis is the baseline angina frequency, and the y-axis, the vertical lines, being the probability of no angina. So if I draw your attention to the graph on the left at 3 months, the blue line showing those patients with a lot of daily angina at baseline. At 3 months, less than 10% of them actually had no angina. Most of them had angina. The red line with the ones with invasive arm, after 3 months, about 15% of these patients actually had no angina. But so still, many of them did have angina. Looking at the lines most on the left. So if you look at the 12-month, the number at the red line actually increased much more than that of the blue line. So if you were getting a lot of angina, looking at the left of the curve, you could see that the red lines diverge from the blue line, particularly on the left side of the curve, demonstrating that there was a lot more effect to relieve angina if you were on the initial invasive strategy. And that was the same at a 36-month line. You could see the red line in patients with a lot of angina, daily angina, weekly angina. At 36 months, more than 50% of these patients actually reported no angina subsequently. So in summary, the curves across the primary endpoint and the major secondary endpoint at approximately 2 years from randomization showed approximately 2 in 100 higher estimated rate of the endpoint with the invasive strategy at 6 months, about 2 in 100 lower estimate rate at the invasive strategy at 4 years. Procedural MIs were increased with invasive strategy with a very stringent criteria. Spontaneous MIs were reduced with an invasive strategy. Low all-cause mortality in both groups despite high-risk clinical characteristics, higher-risk ischemia and extensive coronary disease. But there was no heterogeneity of treatment effect, including by stress tests, severity of ischemia, or extent of CAD, with very low procedure-related stroke and death. So in conclusion, the ischemia was the largest trial of invasive and conservative strategy for patients with stable ischemic heart disease. Overall, an initial invasive strategy as compared with an initial conservative strategy did not demonstrate a reduced risk over a median of 3.3 years for a primary or major secondary endpoint. For quality of life, the patients with stable CAD and moderate severe ischemia had significant durable improvements in angina control and quality of life with an invasive strategy if they had angina, like I mentioned, either daily or weekly or even monthly. In patients with angina, an invasive strategy led to a minimal symptom or quality of life benefits as compared with a conservative strategy. So these were generally asymptomatic patients. However, they concluded also that in patients with angina, a shared decision-making should occur to align the treatment and patient goals and preferences. So a few points to note in our population, and if you look at the eligibility criteria, moderate or severe ischemia by nuclear, echo, CMR, or exercise tolerance tests determined by the core lab was quite significant. But I also draw your attention to the major exclusion criteria. So patients with severe heart failure or heart failure symptoms, refractory angina despite medical therapy, an EF of less than 35%, ACS within 2 months of randomization, CABG within 1 year, and all these patients were actually excluded from this study. Of course, left main stem stenosis were also excluded from this study. So as you can see, this actually forms quite a tight inclusion-exclusion criteria population. In Malaysia, from our PCI registry, in our population, about 60% of our patients are actually elective cases, and 40%, nearly 40% of ACS patients. So in our scenario in Malaysia, there's actually a subset of the 61% of the patients actually relevant to the study population from ischemia. So I think in the APSC perspective, you have to look into your own population. In Malaysia, in 2018, you can see that in our population, approximately 23.96% of the population still remain in the rural population. So, and this is a situation where also access to care, resources, pharmacotherapy, and all these other issues have to be considered, whether you will go by an initial invasive or conservative strategy. So in Malaysia, for a population of 32 million in 2018, we have a population density for cardiologists of 8.8 million, which is a lot less than many of the countries in the region and the APSC. Comparatively, in America, it's about 80 cardiologists per million population, and even in Singapore, much higher than us. I think 20 or 30 per million population. So the density of hospitals with cath lab in Malaysia is still 2.2 per million. So there's still a lot of expansion of the service provision required. And the same in number of hospitals, but the number of clinics remain a lot. So in terms of access to patients and obtaining and providing optimal medical therapy remains a primary source of intervention for most of the developing countries in the APSC. So in the local guidelines, we have the appropriate use criteria, clinical practice guidelines locally for the stable coronary artery disease, and also primary and secondary prevention of cardiovascular disease, all published recently. And for this, for stable coronary artery disease, in terms of relationship with the ischemia study, it is appropriate to consider revascularization locally if the left main stem was 50% or more, if there were a number of vessels with more than 70%, irrespective of the LVEF, refractory symptoms, a large area of ischemia, and this is where we have to apply the entry inclusion exclusion criteria with the ischemia study, and if there was a single remaining coronary artery, more than 50% stenosis. But I note that there are a few other issues in terms of the appropriate use criteria. But again, it was also important to recap the headlines that in November of 2019, the ischemia trial results show that the intervention of stable heart disease no better than drug therapy. The ischemia finds quality of life better with vascularization. Actually, SCAI was not shocked by the ischemia results. And the clinical trialists themselves were surprised to see the overall rate of heart-related events was much lower than the projected 10 years ago. So I go back to the courage, and they show that if I bring again to the comparator of the all-cause death. You remember courage, when it was first published, made a lot of headlines, and the all-cause death there was 7.6% versus 8.3% at 4.6 years, with the 7.6% at the PCI group and 8.3% in the medical therapy group. If you remember here, even the conservative arm of the ischemia study, an all-cause death of 6.4% at 4 years. And that demonstrates how far we have come in terms of management of cardiovascular disease for secondary prevention and primary prevention. Perhaps this is due to broader access of therapy for newer anti-anginal agents, improved stent designs, cardiac CT technology for both speed and resolution, even incorporation of FFR assessments on CD protocols, conventional angiography protocols, and now even wire-free FFR systems. Most importantly, now in 2020, in the era post-ischemia, more highly trained, or what they call the modern era cardiologists, better reimbursement strategies, better dedicated cardiology centers and clinics, a more knowledgeable patient population, and embracing the post-COVID telehealth and digital health solutions, where we can improve and interact better with our patients to manage their cardiovascular and non-cardiovascular risk factors. So with that, acknowledgement of Xavier for some of the slides, and to the APCMC and APSC for providing platform to share these findings. Thank you very much.
Thanks, Alan. That was fantastic. So I guess the first question I have for you is does this kind of strengthen the argument for kind of use of kind of a more extensive workup for patients in terms of making the decisions? I mean, given that, you know, these patients fairly extensively had evidence of ischemia, had a lot of them had CTCA. Does it strengthen the argument for patients being more extensively worked up before we make these decisions about revascularization?
Yeah, I think this study is important, particularly in the era, this modern era of cardiology, where many of the younger cohort of cardiologists seem to favor or think weigh heavily upon the revascularization component, to try and stent, to try and give them aggressive therapy such as CABG. But we should not ignore the findings of this study looking at the pharmacotherapy component. Some of these trials use the word conservative therapy or conservative arm. I think these days, you know, with dapagliflozin and, you know, SGLT2s, EPA, these are very aggressive interventions. I think applied in the right manner, I think can reduce cardiovascular events in stable ischemic heart disease patients. So not only the workup is important, but the tools that we have to do that, the interventions from a pharmacotherapy aspect actually there. So I think it's reassuring to know, and I don't regret not undertaking a very deep CTO fellowship at this point in time.
Yeah, no, look, and you know, I think it is an important point to make. I mean, I think that we use the word conservative. There's nothing conservative about the way that we want to medically manage patients today. It's aggressive, but it is going to make it hard to show a benefit above and beyond that. And that's why studies like this are important, to try and identify where we think those benefits may be and where they may not be. You told us a lot about the quality of life and the symptoms, and you know, again, the value of something is a little bit in the eyes of the beholder. So if I'm a healthcare system or a payer, I may look at the results of ischemia in a one way. If I'm a highly symptomatic patient looking from a patient-reported outcome measure, I may still find that there's a benefit from having an invasive approach, particularly if I had a fairly high burden of ischemia. Would that be fair to say?
Yeah, absolutely right. I think there's a big difference between playing the Australian Open and the commentating on Australian Open. I think if you really were exerting yourself and requiring that kind of thing, I think you know, having revascularization will weigh a little bit more compared to somebody who is more sedentary. So I think, you know, it's reassuring very much, especially in an era where, you know, patients only feel that they get proper treatment if they get a stent or bypass surgery by, you know, where if you have access to a clinic, a non-interventional facility, that you could get equally good outcomes, you know, if you have stable CAD and then being managed aggressively as per the guidelines. I think this is a very important study to refer to these days.
KK, we're getting close to the end of the hour. We might, we'll leave the last word to ischemia to you before we look to wrap up.
Yes, well, you know, I think ischemia is one of those trials that has informed us about the safety, the ongoing safety of medical therapy in stable patients. I just want to highlight that perhaps the hardest thing about ischemia was really about recruitment. I know that our center struggled to recruit patients, and not because of lack of effort, but really the patients themselves were very, you know, resistant to the idea, and you know, physicians themselves also felt uncomfortable putting, you know, patients with ischemia on the ischemia trial. So I think that does affect our use of the data. But if nothing else, I really feel that this is a study that has reassured us that medical therapy does work and we don't have to rush to PCI. So in clinic, if somebody doesn't want PCI, I say, oh, great, you can just, continue medical therapy because we have sufficient data and good quality data to show that it can be safe as well. So I'll let Steve, you could close the session.
Yeah, so look, the one last comment I'd say in thanking Alan for his talk is Alan started by paying respect to Judith Hochman, and I think that can't be understated. It can't be stated enough. I mean, she asks the bigger questions, and she takes on clinical trials which aren't easy to enroll, but they are really vital to answer the questions, and so. She's a bit of a hero of mine kind of as well. One question that has come up on our Facebook page during the seminar has been around the mechanisms that tie SGLT2 inhibitors to heart failure benefit. And, Natalie Coe has kind of shared some information on that. We'd be happy to kind of follow up. I mean, I think that would be fair to say that there is an enormous amount of work that's ongoing at the moment to try and understand that. The position statements certainly outline a range of putative properties of SGLT2 inhibitors that we think should have both a vascular, myocardial, and kind of fluid benefits. So it's probably going to be the combination, but I think the whole generation of studies moving forward will help us understand that. So look, on that note, this has been a really exciting 90 minutes. It's been the first of hopefully what will be many of these types of events for our collaboration between the APSC and the APCMC. I would like to thank each of our speakers today. It's been just outstanding, and my co-chair who always manages these things with consummate kind of ease, KK. But we've gone around the backyard here in terms of kind of cardiovascular disease. We've talked about genetics, we've talked about blood pressure and LDL, we've talked about fish oils, we've then gone on to how we take diabetes drugs and use them in heart failure, and then we finally finished with how do we kind of balance the cath lab yes or no for patients with regards to kind of ischemic kind of heart disease. And I think it's been a really exciting time in the last few years for clinical trials, and we've been able to talk a little bit about that today. Thank you for joining us for this, and we look forward to meeting with you again. Enjoy the rest of your weekend. Bye.
Thank you very much, everyone.
Very much.
Thank you very much. Goodbye.
Bye.
Bye.